To Mr. Carter, 5 minutes for your questions, please.
Thank you, Mr. Chairman, and thank all of you for being here. This is certainly a very important hearing. I want to start with you, Dr. Weinstein. Full disclosure, before I became a member of Congress, I was an independent retail pharmacist, so I appreciate independent healthcare practices. You know, when I talk to my colleagues about the problems that we're having hanging on to independent retail pharmacies, they think I'm only talking about independent retail pharmacies, but I'm not. I'm talking about independent healthcare practices. That to me is a real big problem here. And one of the things I wanted to ask you to begin with is I'm really troubled to hear that you're having trouble with that your practice is having trouble with participating in some of these cost-saving arrangements with Medicare because of the outdated CMS policies. And I just wanted to ask you, what do you think are some of the advantages that perhaps the big hospital systems have over you being an independent practice? Can you think right off of some?
Well, again, you know, hospital systems are really just people. So it's, you know, the big hospital systems, I guess you might say that for the really complex tertiary care, complicated surgical, infectious disease, somebody with multi-system disease needing multi-specialists, obviously hospital systems are important. But many of the diseases that we take care of are really isolated to gastroenterology or maybe gastroenterology and surgery, so one or two specialties. And that is, the idea is to be able to get to those people, engage those patients before they need major hospitalization. Right. That's where the savings is, and engaging those patients. I mean, the Project Sonar that I mentioned before, which was tentatively approved by PTAC, but then didn't move forward, is a technology engagement with patients to determine how they're doing on a basis where they might ignore symptoms from time to time and engage them before they get to hospital. So there's certainly need for hospital systems for the very acutely sick, but the majority of patients hopefully can avoid hospital.
Absolutely. Well, thank you, and good luck. I'm pulling for you. Trust me.
Thank you.
Mr. Reed, I want to go to you because I'm very interested in this. I've had a company in my office that and helped me to articulate this because I suspect you know about it better than I do. But they're coming to Georgia now, and they are involved. They have an app that they've created because in Georgia right now it takes 3 weeks on average to get an appointment with a primary care physician. And in some areas, particularly in the area that I represent, South Georgia, a very rural area, it may take even longer to get that. Well, they've come out with an app that can take advantage of cancellations or changes in the schedule. And you can use that app, but they're telling me that the only way they can bill for it outside of the private pay, the only way they can bill for it for the Medicare patients is if they do it by a flat fee. And they want to do it on a per usage basis. Again, I'm sure you understand that much better than me, but the rules are so antiquated that they can't do it.
That's correct. You know, I had my staff prior to this hearing pull through my written testimony and come up with a glossary of 44 different acronyms that I use just for my testimony. And I'm pretty sure that everybody here has the same number. But that really represents the status that your company in the great state of Georgia is dealing with. The problem that they face is they also get completely differing answers. For example, on the one you're talking about, when you look to share that information on an application like that on how you bill, you've got to deal with a couple of different systems. Not only from an interoperability perspective, but also how do you do the data sharing? Right now, they can do a flat fee that somebody pays, but if you try to do a per physician basis pay, there's no mechanism by which it processes through the Medicare or Medicaid system. So they're really stuck out there in the fee-for-service or private payer model. And it makes no sense because, as you say, when somebody drops off of an appointment that they can't get to, especially in areas like yours with a healthcare professional shortage area, this is the exact time that you want somebody to say, hey, I need that patient. And as I said at the beginning, this demographic problem is only going to get worse, not better. So when it comes to the model, we really don't see we don't see CMS really providing pathways for those kind of innovative products at all.
Good. Okay, well, I see I'm out of time. Thank you, and I yield back.
Chair, thank